Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. Today, I'm going to share with you this very unusual case of a cervical carcinoma presenting with bladder mass and hematuria. So this is a 72-year-old female patient who presented with hematuria and was found on investigation to have a urinary bladder mass. And this was the TURB. So as you can see, the surface part of the fragments of tissue appear to be lined by urothelium, but are unremarkable. What we can see here that there is a tumor actually getting into the bladder wall or invading the bladder wall from outside the bladder. And this is a very important tip that we should really be careful with or pay attention to. Some fragments, now I have to say, some fragments of sometimes urothelial carcinoma would show this appearance, but other fragments will show the continuity with the surface epithelium. But in this particular case, there was no evidence at all of surface epithelium involvement or really even approximation of the tumor to the surface epithelium. So this is an important clue or tip that we should pay attention to. And on high power magnification, the tumor really looked very so undifferentiated or poorly differentiated with high NC ratio, frequent apoptosis and mitosis, and perhaps some suggestion of some glandular differentiation, and here as well as if this is within a vascular space, again supporting or suggesting that this might be a carcinoma coming from outside the urinary bladder, and then again just to highlight the infiltration that was encountered toward the edge of the tumor, and this is the muscle, the trochanter muscle of the bladder, with really tumor infiltrating in between the muscle fibers. And we have really to resort to immunohistochemistry to solve out this dilemma in the diagnosis in association with the clinical correlation, because it's extremely important, and I will explain this at the end of the presentation. So GATA3, we know that GATA3 is usually positive in the urothelium, and it's usually positive in most urothelial carcinomas. This tumor was completely negative, and this is on high power magnification. But we have also to remember that some cases of urothelial carcinomas, especially the high-grade ones, or the ones showing, for example, in neuroendocrine differentiation, might be negative. So this is not an absolute exclusion criteria. Cytokeratin 7 was beautifully positive, while cytokeratin 20 was completely negative. So this again tend in a way to make the diagnosis of urothelial carcinoma less likely. Now, because she is a female, and because we know that cervical carcinomas sometimes can invade into the bladder, I almost always try to exclude cervical carcinoma or female genital tract tumor invading into the bladder. And PAX8 was beautifully positive in the tumor cells at more than one focus, and then P16 showed positive staining. Now, at this stage, I contacted the physician and I told him exactly of the findings. And when we reviewed the radiology reports together, there was a mass in the cervix and the vagina invading the bladder, but at that time, initially, because of the patient's presentation, it was thought that it was the bladder cancer invading the cervix as well as the vagina. So it was actually the other way around. Now, one small just a reminder that P16 can sometimes be encountered in urothelial carcinoma. So P16 alone will not be sufficient to render the diagnosis. We have to have the panel of immunohistochemistry. So we have the negative GATA3, negative cytokeratin 20, positive PAX8, and then the P16 would really support that this is of cervical origin. So the final diagnosis in this case, in correlation with the clinical as well as the radiological findings, was cervical carcinoma invading the urinary bladder. I hope you find this tip useful in your daily practice. Thank you.